Welcome to this afternoon's session. Hope you had a good lunch and caught up with some people. I mentioned this morning that one of the key initiatives we're going to be looking for in 2018 is around bundle payments. Exactly how we were going to go about it, we don't know yet, but we do know it is a program, a kind of a value-based purchasing program that others around the country are doing, and we're really grateful that we have somebody from Marcia Peterson from Washington State to talk to us about today. The coalition is fully committed to trying to do some value-based purchasing to make those opportunities available for our purchaser community, work with providers in making it happen. I think the collaboration there is really important. I love the title, multi-stakeholder approaches to bundle payments. Although the board at the coalition is purchaser only at this point, it does not mean we aren't going to do full-on collaboration where necessary with willing partners to move towards these value-based purchasing type programs. The cool thing about what's going on in Washington State is the criteria for the bundles were developed with providers, by providers through the BRE Collaborative, which was set up by the state legislature. And so I think it's a really interesting tale we want to hear about. Some folks are going to say bundles are too hard. Some health plans are not going to want to do it. We know fee for service, we don't know bundles. It's a world that we are not ready for. And what I want to do is just refer to an article that was in Modern Healthcare a number of months ago. And it was the editor emeritus, a guy named Merrill Guzner, I don't know if you know him, and he was talking about the fact that CMS is going to back off from their mandatory bundles. And he was quoting CMS about why that would happen, and he said the CMS highlighted the opposition to mandatory bundles by, quote, many commentators that it would, quote, force many providers who lack familiarity or the experience or proper infrastructure to quickly support care redesign efforts for a new bundled payment system, end quote. The editor's comment was, yes, it would, and that's the point, okay? And this is some of the hard work that we need to do if we are going to tackle some of the things that Elizabeth Rosenthal laid out for us this morning. So with that, I would like to introduce Marcia Peterson, all the way from Washington State, corner to quarter, across the top of the country, about as far as you could go. I guess Marcia is the manager of benefit design and strategy for the Washington State Health Care Authority Public Employees Benefits Program. And that program is responsible for purchasing and managing benefits for 350,000 beneficiaries within the state. I don't think that's insignificant because one issue around bundle payments is going to be volume, and this is something that we're going to have to figure out in Maine to have enough volume for the program so that at least in preliminary discussions, the providers think it's worth doing. So they have 350,000, but we have about 175,000 covered lives in the coalition right now, so we're going to do this. Marcia has a bunch of other past experiences. She's worked on the provider side as director of strategy for the Swedish health system, so forth. I could go on, but I'd rather just have Marcia come up and talk to you about bundles and what is actually working. You remember a year ago that we had Olivia Ross from PBGH talking about bundles. I think Marcia was telling me at lunch that Olivia helped them. And the way we're doing these programs with the coalition, for instance, group purchasing of RX and now bundles, is we're finding people that have actually done it and have been successful. So this is not pie in the sky stuff. This is not stuff that plans can't do. It's not something that purchasers can't take the lead on if we simply have people that are willing to do it. So as an example, let's take a look at what's going on in Washington State. Marcia.
So am I on? Am I mic? Good. You can hear me. Well, I am very pleased to be here in the great state of Maine. I've never been here before, but as you said, it's pretty far from the left coast to the right coast, but it's absolutely gorgeous, and I commend all of you for being here on this gorgeous October day outside. But I guess it's like this every day, isn't it, here in Maine? I don't know, that's what they tell me. Well, I'm also just really pleased to be at this purchasers conference. We have we have the Washington Health Alliance within Washington that we are members of that does very similar things, and we have a purchasers association as part of that. And we would be very proud to be putting on a conference of the quality of this and the quality of the speakers. Here I am putting myself there, but I am very happy to have gotten to see Elizabeth Rosenthal and also Jeff Brown earlier on patient safety. You've got some really great speakers here, so maybe I'll come back next year and just participate. So I'm here to talk about multi-stakeholder approaches to bundled payments and how we did it in Washington State. Sometimes I like to just call this talk, Healthcare Can Be Simple. Who knew, right? Or it's totally possible, because it really is totally possible. So I think we have until 3 o'clock. And I'm going to talk and hopefully at least leave time for questions. I'm happy to answer questions for those of you who are interested, and I can even stay around later if you'd like. But overview, I'm going to talk a little bit about who we are at the Healthcare Authority. As Michael mentioned, I want to talk about the BRE Collaborative. That will be throughout the whole presentation. Give an overview of our strategy, our approach, our rationale, why we did this. I want to talk about results. Very few, I have found, who give presentations on this actually talk about their results. And as a purchaser, you kind of care about that. Did you save money? And then what comes next? So that's kind of an overview. So first, Healthcare Authority. The Washington State Healthcare Authority is an agency located in Olympia, Washington, which is where our capital is. The capital of Washington is Olympia, and it's about 60 miles south of Seattle. We also have Medicaid within our program. We have Medicaid and also the public employees. So together it's about 2.2 million. About 1 in 3 people in the state under age 65, about 1 in 3 under age 65 get their health care through us. So we're a big purchaser. Now a lot of that is Medicaid. Also, we woke up on July 1st after our state legislature and the governor signed the budget for the next biennium, averting a shutdown of the government. And we woke up and found that they had decided that we would also now purchase services, healthcare services, for all of the school employees as well. So that about doubles us. So we'll be about more than 500,000 of just public and school employees. And we're trying to figure out how on earth we're going to do that. So very exciting. We also, as part of a state, and a lot of states are first movers and very innovative in trying to transform care, and we take that very seriously. We have a goal that by 2021, 50% of our commercial health care, 90% of state-financed care altogether will be in some sort of value-based payment arrangement. We recently contracted, a couple of years ago, did an arrangement with our self-insured plan where we have a couple of accountable care networks. Similar, if you're familiar with what Boeing did with their accountable care networks, we did something very, very similar on that. And so everyone was really focused on that and spending a lot of consulting money on our accountable care network. And then somebody said, you know, we should do bundles too. Would you do that? And I was like, well, yeah, I've always wanted to do bundles. And so as Michael said, we got a lot of free help because we didn't have any money for consulting. But we got a lot of free help from people like Olivia Ross and others who had done this before. And that was really great and kind of stumbled our way along. But we came up with a really great product. So happy to talk about that. So first, the BRE Collaborative, what is it? So that it's named after Dr. Robert BRE. But it was established in 2011 by the Washington State Legislature. And what they did was they brought together a group of both public and private healthcare stakeholders. So it includes purchasers, it includes providers, and others as well. And what they do every year is that they try to identify several areas for improvement in healthcare that they're going to work on. And you can see what some of those are on the side there, some of the things that they've worked on. They develop reports. They specifically try to focus on areas where there's high variation in quality, or areas where that are frequently used, but there's questionable outcomes on those, or if there's patient safety issues. And they develop a set of standards, and they're essentially guidelines. They're completely voluntary for providers to use or not. And in fact, I would say probably most providers in the state, up until maybe a year ago, were not even, a lot of them weren't even aware. If you said BRIE Collaborative, they didn't know what you were talking about. They became aware when the healthcare authority started saying, oh, and by the way, if you want to have our patients, our members go to you, provider, you will be following the BRIE standards or you will not get paid. So we've increasingly tried to bring the BRIE standards into our contracts. And one of the ways that we did that was in this total knee and hip replacement bundle. So this graphic actually comes right from the BRIE Collaborative report on total hip and knee replacement and their bundle. And what they did was they looked at the variation in 30-day readmission rates for total hip replacement patients, and they looked at it by hospital. So every one of those lines, you can see they're blinded. I have a laser here, so be careful. These are all hospitals that have been blinded. And along the side are the readmission rates. So you can see you probably don't want to be at hospital 1 or hospital 5 and so on that have over 15% readmission rates. Readmission is a proxy for quality. If someone goes through a hip replacement and develops an infection, they may be readmitted. So that was of clear concern, and we wondered about that for ourselves. So for our own members, we also ran a similar report and found some variation in quality as well. Come on. We also found great variation in costs for each of these hospitals. Now, these are average costs that I'm showing, so by number of procedures. So each one of these dots it identifies or is a hospital where our patients get care, our members get care. So these are the top ones. Obviously, there were lots of others. But you can see for some of the highest, where 80 of our patients, over 80, received care at some of the highest cost up there. So huge variation. So we began to really wonder about that and think, well, maybe this is something that we should really look at for a bundled payment approach. We, for our members within this self-insured group, about 600 of them each year, there's about 350,000 of them, but about 600 hip and knee procedures are done every year. And I'm sure you know that hip and knee replacement has come a long way in the last 20 years or so, and really has the ability to really change people's lives and their ability to, their quality of life. But it is the fastest growing procedure among folks between 45 and 65. And we suspect that there are a lot of people who are having hip and knee replacement done who probably don't need it, or maybe it's not the best choice for them given their lifestyle and what they want. So lots of, close to 20 million in costs. So we decided that that would be a good place to start. So quality was a consideration, a top consideration. We also were concerned about cost as well. We wanted value for our money. But also we were interested in the member experience. And I represent that with a coffee cup, not just because I'm from Seattle and Starbucks is from there after all. I mean, how can I have a conversation without talking about Starbucks? But the member experience, and we like to talk about, if we bought healthcare, if we bought coffee like we buy healthcare, it would be a horrible experience. If we walked into Starbucks and they handed us a coffee cup, and then we had to go somewhere else and buy some beans, and then try to get somebody to grind it for us, and maybe find some water, and then get someone to heat it. That's kind of what healthcare is like for people. It would be a terrible experience. And we put up with that, and it's ridiculous. I've worked my entire career in healthcare. mostly on the provider side. And it's always been something that we've talked about. How do we improve the quality? How do we improve the experience? So we felt that this bundled payment, this approach of bundling care together, getting the providers together to talk about what's the best way to provide care, was a way to improve the member experience. So here's a little overview of what we did. Our Center of Excellence for Total Joint Replacement, we rolled that out to our members in January of this year. So our members who need a hip or knee replacement, if they go to the Center of Excellence that we've designated, then they have no out-of-pocket cost, no out-of-pocket cost. The CDHP folks have to meet their deductible because that's an IRS regulation, but other than that, no out-of-pocket cost to go to the Center of Excellence. Plus, we pay for their travel, their lodging for them, and a care companion. And the care companion, I'm going to talk more about this in a minute, but the care companion, having a care companion as part of this, a care companion means your spouse or your sister or whoever goes with you, an adult, who stays with you, and it's a requirement of BRIE that you have a care companion. It's an evidence-based method for ensuring good outcomes. But anyway, so what we did was we said in 2015, we decided to put out an RFP for a Center of Excellence, and all of the criteria was based on the BRIE criteria. So again, we purchased based on BRIE criteria. We thought we let everybody know about it, but one of the things you'll find if you'll do this is providers are not used to doing this kind of contracting. They don't get on the Washington Healthcare Authority site and to look at what kind of RFPs we have out there because nobody's doing direct contracting. So we sent out this RFP, and then around the time that it closed, they started to hear about it. And then they were really mad because they were like, you didn't give us enough time. So we kept extending it a couple of months. And we eventually got responses from 14 providers all across the state. We ended up selecting one because only one met the criteria fully, we felt. And this was really hard for us because we went out there thinking, well, we'll probably get, and we have members in every part of the state, all over the place. And we thought, well, it'd be great if we could kind of get geographically dispersed, maybe one in each corner of the state. But when we looked at all the criteria, we only found one that really met the criteria. They were up here, Virginia Mason, and everybody else was kind of down here, getting there. And we just didn't feel good about saying, okay, Center of Excellence and Center of Adequacy. We just weren't willing to put our members through that. So we selected one. And we selected Virginia Mason. They are one of the centers of excellence for Lowe's, for Walmart's, for their bundles. You've heard of them. And what we found, and this is this picture is us. It's the healthcare purchasers out there, the top five providers who applied. We went out and actually did site visits. And so this was at one place where we had on the bunny suits and went through the ORs. And that's quite an experience for people who are just normally purchasers and have never done that before. It's quite eye-opening. But what we found when we went out there was just a really distinctly different approach with an organization like Virginia Mason. I don't mean to say that y'all need to go contract with Virginia Mason. There's other providers out there who get it. What they get is they re-engineered all their processes. They're all about lean. They have a team approach with physician leadership. And that last thing was the thing that stood out to us the most. And you'll find that if you talk to providers and go out and start talking about this. There were providers where we found that there was a really dedicated team in the hospital, a dedicated nurse who would go out to the providers and tell them, well, hey, we came up with some new protocols, we've kind of changed it. And we felt that that wasn't enough. What we saw at Virginia Mason was a truly team-based approach where the surgeons were in the lead, and they were in the lead in the sense that they were totally bought into it. They were leading these lean processes. So that's what you want to look for. We also sat in on huddles where the whole team was involved, where the person cleaning the room also was part of that huddle and was just as important as everyone else in talking about safety, similar to your talk earlier, right? But this is hard to do, right? This is really hard to do this approach. And the approach that we wanted to take, I'm going to talk about a little bit more in a minute, is a prospective payment approach to bundled payments, where we just wanted to have a negotiated rate, which is what they did. We negotiate a rate, let's say it's $25,000. And when somebody goes through and has their hip replacement, Premera turns around within a week, I think it is, and pays them $25,000. Done. You guys figure it out. We didn't want to be in the situation, we didn't want to have pre-authorizations, we didn't want to be in any situation of trying to figure out who should get what kind of money. We just wanted it to be simple. We wanted healthcare to be simple. And we wanted to incentivize the providers to work together. And that, we felt, was the best way to do it, was this approach to payment. And our administrator said, nice idea, really hard to do. We just can't handle it. So we said, great. So we went out for a second procurement very quickly after for another TPA who could handle this approach to payment. And Premera ended up getting it. Premera Blue Cross, I should say, is our local. And so this was really a team approach of the purchaser, of us, together with Premera, the plan, and Virginia Mason working together to create a great experience. So what's included in the bundle is always a question. It's defined within the BRE criteria, but even within that, there are a number of things that you can include and not. So what's included in their bid that they gave to us, we defined the pre-surgical visit. So patient goes the night before, has the pre-surgical visit, goes through all of the paperwork, et cetera. They identify whether or not you were actually lying when you said that you had quit smoking. Are you really, is that your BMI? Are you actually at that weight? And so on. They confirm all of that the night before. Incidentally, they stay the night before in the Virginia Mason Inn, which is right next door. So it includes basically the hospital stay and all of those things that are on there, including DME. One of the things that we learned, and this was from Olivia Ross when she was I was getting free consultation from her. How are they going to bid on this? What you include, you as purchasers include in that bundle is very important because if you include things like, you'll notice SNF is not on here, skilled nursing is not on here. If you look at a Medicare bundle, skilled nursing is a huge piece of their costs, and so they include that in the bundle. And for most commercial populations, they never go to a SNF, so don't include it. Don't include something that doesn't happen more than 50% of the time. So DME, which is usually a walker, that's included in here. One thing that I wanted to mention when Elizabeth Rosenthal earlier was talking about reference pricing, we looked at reference pricing as a possible approach to bundled payment. Let's see if we would do that. And the concern we had about reference pricing was putting the whole risk on the consumer, on the member themselves. So we were really worried about additional costs. So you may think that you're going to pay $14,000 and go for your hospital stay, but you didn't know that they were going to do 3 more imaging tests and all kinds of other things. And they can just throw those in there and you'll see all those costs on your bill. We didn't want that. And that in the Health Affairs article, I think it talks about that as one of the challenges of reference pricing. So we just went, we don't want our members to go through that. We don't want any surprise bills. So everything is included. If the hospitalist pokes his head in, if they do 25 MRIs, it's the same fee. We didn't want them to have any costs on top of it. And in addition, we didn't want to have any costs related to transportation, lodging, et cetera. Premera actually is very much a concierge approach on this. So they kind of hold your hand through it if you're the member, through the whole thing. They gather your medical records together, give them to Virginia Mason. Virginia Mason surgeons look through them, call you on the phone, talk to you about whether or not this is the right thing for you to do. That's all part of the cost as well. They also arrange Premera has, one of their clients is Alaska Airlines. And so they have an agreement with Alaska Airlines that if one of our members needs to fly across the state to do this, they arrange all of that. So it's an itinerary sort of travel approach, and not every administrator can do that. The other thing, I always like to talk about parking. So in the midst of our negotiation and trying to implement this with Virginia Mason and Premera, it occurred to us that our members were going to get a parking fee. Now, Virginia Mason is located in downtown Seattle, high parking costs. And I used to work in hospitals, and I used to read the patient satisfaction surveys. And any providers in the room, you ever read those surveys? You read those surveys, and they're like, oh, you saved my life. It was great. The nurses, the doctors, I loved everything. And then I went out to the parking garage, and it was like $200 to get out of your lot. And then they hate you. They absolutely hate you. It doesn't matter that you saved their lives. So we said, we're not going to do that. Parking's going to be included. Now, we're paying for it, right? But parking's included. We want people to just drive out. And Virginia Mason just said, that's really hard to do. It's really hard. And we said, yeah, healthcare's hard. It ain't brain surgery, though. You guys do brain surgery, don't you? Yeah, we do. Okay, you do parking. It is hard, and it's funny. Those things that seem so simple, parking, that they're like, whatever, we saved your life. It's like, that's really important to the member. It's that whole experience. Healthcare should be like this. I always say, of course it's hard, but it can be done. And we did it. And they're still struggling with it a little bit. Most hospitals don't even own the garages. And the guy who takes at the kiosk, he doesn't speak English. So how are we going to do that? And we're like, Toyota Lean, you guys are the experts. Go and figure it out. BRIE also includes a 90-day warranty for complications. So any complications related to the surgery, only related to the surgery, the hospital's at risk for that. So they would be readmitted totally at risk. And as I mentioned, no out-of-pocket costs. So this is, as I said, we worked together. This was right at the beginning, after we were in the midst of signing the contracts, but we're implementing it. And we call it Workflow Day, and this was the first time we'd all gotten together. And this was a full day with Virginia Mason, Lean people. There's us, the healthcare authority, the purchasers are there. We have our billing people there. We have, from Virginia Mason, there are physicians and billers and Premera. I mean, every level was there. And we had yellow stickies all over the place. And it was really exciting, especially for me. I've worked on the provider side almost my whole career, to be able to have these two organizations, these three organizations working together and continually saying, what does the member need at this point? And what does the member need at this point? All the way along. What we really did is we redesigned care. And that's what this sort of approach can help you do. This is a graphic that Premera put together to talk about the customer experience, sort of from the point where the member is saying, ouch, my knee hurts. I want to learn more, and so on and so forth. So for each one of these points along the way, this one is, I'm having surgery. They developed a customer journey map. So the customer experience is, I know who my caregiver will be, and they understand their responsibilities. I understand my travel options and plans, and so on. And then they defined how the program was going to support each one of those steps along the way. And you can see those up there. And the thing that what everybody kept in mind was we want our customers, we want our members to say, I'm taken care of all along the way. So how do we get them to do that? Premera put together a website for our members to learn more. So they send them there, or they can just go there on their own. You can Google this and find this yourself. Just do Premera hip replacement, and you'll find it. And so there's a lot of information up there on, what to expect, and here's the travel benefit and FAQs. But they really do need to call Premera in order to get this whole thing started. Okay, now we're going to get a little policy wonkish on you. Sorry, health policy, here we go. But I want to talk about retrospective payment and prospective payment, for you to understand sort of the difference and the nuance, and decide for yourself if you're going to do one of these programs, decide the approach that you want to take. So retrospective payment, most bundled payment programs, including all of the Medicare programs, are retrospective in nature, which is they figured it all out at the end. So as my graphic shows, as the patient goes through all of the care at the hospital or wherever they are along their journey of having their hip replaced, all of the providers, everything's paid for on a fee-for-service basis, just as it is today. Just as it is today. And then at the end of the year, and I'm oversimplifying, but at the end of the year, Medicare, if they're the payer, will say, okay, well, in your market hospital, the target price, the average price was $25,000. When we added up all of those costs that we say are in the bundle, all those costs, all these things on here, you actually spent more than that. So you owe us money, sorry. Or you actually spent less than that. So you get to share in the savings. So that's kind of how those things work. So the incentive is that you should know your costs, you have an incentive to continue to work on it, and hopefully in a year you might see some savings. But it's a little bit hard to know at the time. But that's how most bundled payment programs work. And it's a great way to go, and I want to encourage you, if that's your first step, go for it. Most health plans can handle this sort of thing. But we wanted to do prospective payment. We wanted that approach. We wanted healthcare to be simple. Healthcare should be simple. Why is it so complicated? So what we wanted was, here's $25,000. Goodbye. Let us know how the quality went. If your quality is not good, then basically we're not going to contract with you anymore. But this is it. And if you want to spend part of that money on a limousine driver to pick up people at the airport and take them to the hospital, fine. And by the way, they do. Virginia Mason picks up someone at the hospital in a town car. And that's just part of it. We wanted to get out of that whole thing of, health plans are saying, this is included and this isn't, and we're going to pay for this and not pay for this. And you can see it puts them at risk for everything, too, that they pay for. It all needs to be around the quality. So that was why we decided to go with prospective payment. It's not easy for folks to figure out, for billers to figure out. Virginia Mason they already had experience with it, but it's not standard. But it's an approach that we thought got the whole team together to talk and to have the same goals. And it seems to be pretty effective. So you wanted to hear about stakeholders. Some of our stakeholders, of course, we're the state, and we purchase services for all kinds of agencies, the State Patrol, Department of Corrections. We have higher ed, University of Washington. We purchase services, healthcare services for them. So a lot of those folks are unionized as well. And as you know, it can be challenging coming forward with some of these value-based payment arrangements when you're talking to labor. In the last few years, especially on the state side, if you're talking about benefits, it's usually not good news, right? It's usually something less that you're going to be getting. So we knew that they would be suspicious. And I have to say the reason it worked so well is because we always led with quality. It was, and Bree was our true north. We always talked about quality, and we never talked about cost. Frankly, we hoped that we would break even on this. And we took a little bit of a risk with the legislature on that, but I'll talk about the results in a minute. But I think if you lead with quality, and you're always talking about that, what's not to like about it? Another stakeholder, of course, the hospitals, the Washington State Hospital Association, wasn't that happy with what we did. Of course, they represent their members. And one of the things that they kind of called us on the carpet about was, this is so bad for our rural hospitals. What about rural hospitals? They're having a hard time keeping orthopedists within their community. This just takes money out of their pocket, which we said, right, healthcare is broken. Like, it's broken. We're trying to fix it, but we might not be able to fix that. But how can we, in good conscience, say to our members, we're going to pay for you to go to some place that's not highest quality? I mean, we do, because this is a voluntary program. But we don't have a good answer for the Hospital Association other than get your members on board. And then there's the legislature, all of whom have hospitals in their districts. And several of them have written us letters over and over to question what we're doing. And we always come back and say, you told us to do this value-based purchasing thing. And we're following BRE Collaborative, which, by the way, you put together. So we keep coming back to that. But we do have a bit of pushback. Actually, one of the physicians at Virginia Mason, Dr. Mecklenburg, is a fabulous guy, and he's one of these people who is just full of quotes all the time. And he always says, you know you're getting close to the treasure when the dragons come out, right? So when you start getting a lot of these letters, you know you're hitting something that you probably should. So a little bit about BRE. This is actually one of the slides that I showed to the Public Employees Benefits Board. Labor sits on that. Because I wanted to, and this was really early on, to say, well, we're thinking of doing this. So BRE standards for a surgical team, there's lots and lots of these, but this was just taking out, because I said, how many of you as a consumer would ask these kinds of questions or know these sorts of things about your surgeon? That they have to have a certain level of volume, that all of the surgical team has to have these kinds of documented credentials. This was my favorite one, that the knee replacement must be scheduled to begin before 5 p.m. I mean, who even knows that they should ask for that? And then they need to be accredited. So showing those kinds of things to the folks who are our members kind of brought it home to them that, wow, we really don't know about quality. You were talking earlier about the, what was that, the A plus standard or whatever that hospitals, the safety awards, which is basically meaningless. I mean, hospitals put these things up and consumers are just like, wow, yeah, it must be good. But this sort of thing is the sort of thing that as a purchaser, we should be vetting. We should be vetting the places that we're sending our members to. And this is a way to do it. But here's one of our letters that we got really recently, actually. I don't expect you to read it, but it's from one of the providers that did not get chosen in our hip and knee replacement. And they're writing to us to express concern regarding our decision to direct joint replacement patients to Virginia Mason. It's causing a significant disruption to our practice and our patients who now have to travel to get care and so on and so forth. Causing significant disruption to their practice. And we're going to probably see more of this. So I'll talk in a little while about how our next bundled payment, how we're going to try to kind of mitigate that a little bit, but without any sort of change in quality. The results, I think, speak for themselves. So these are results as of October 3rd. As of October 3rd, we'd had 76 surgeries completed. Now remember, we have about 600 each year, right? So it's a little over, around 10% we're getting, which may seem low. But when I called around and we did all of my consulting with Lowe's, Walmart's, all of those, they said, you'll be lucky if you get 10% to convert and do this in the first year, even with all your incentives and all of that and the marketing. 10% in the first year. So we feel like we're doing pretty well. We sent out evaluations to all of the folks, or Primera actually sent out evaluations, and they all said that they would recommend the program. They all said they'd choose it again. They rated it 9 out of 10, 9 or 10 out of 10, and they thought the whole organizing was well handled. It's been a good experience. Oops. There we go. And we're getting people from all over the state. So this little green dot here, this is where Virginia Mason is located in King County. We're down here, by the way. So, and then there's a big mountain range that goes in the middle of the state that's hard to get over in the wintertime, but we still have people coming across. So they're coming from all over. And so here's the bottom line here. The costs per paid total joint replacement, about 1.2% is going to administration and 2.4% is going to travel. And our savings at this point is 17% over the previous years. And we will break even when we get to about 90. We will have paid all of our upfront costs. So next year it'll be even higher. And I should mention, Virginia Mason was not the lowest cost provider. When we put together our criteria for the RFP, we were very concerned. We didn't want anyone to win based on the fact that they were the lowest cost and didn't have the best quality. And that's really tricky. And so we weighted the non-cost criteria, all of the quality criteria, 2/3 compared with 1/3. So Virginia Mason was not the lowest cost. They weren't the highest cost, but they were definitely not the lowest cost. But even so, we're saving over what we had in the past, and our patients are getting the best quality. And so some comments from the members. It was really easy to learn about the program. They got walked through everything. I would be a poster boy for your program. I wish I knew that person because I do want him to be a poster boy for the program. I want them to do a testimonial. I know that's one of the things that Lowe's has out there is a guy talking about it. I mean, having one of your fellow employees say, this was fabulous. Because I think people look at it and they're like, this sounds too good to be true. What's the fine print? So we feel really good about the quality that we're getting. One of the questions that you get a lot about bundled payment, one of the criticisms that like policy people will say is, great, you just negotiated a lower rate on something that maybe this patient didn't need in the first place. And it's true. I went to a conference recently where a provider, it was an orthopedic surgeon, I think he was from Houston, who feels really passionate about quality and trying to do bundled payment. And he said that he put up an x-ray like this. He said that there was a patient that had come to him who'd had knee replacement several years before, and she was having a lot of pain in her knee. And he couldn't figure out why. And so he was able to get a hold of the x-rays from before the surgery. And she had no osteoarthritis. She did not have a problem that needed to be solved with a knee replacement. So unnecessary surgery, unbelievable. And he was just aghast. He was like, what's the point? You're negotiating a lower rate. And he just kept saying, where are the purchasers? Where are the purchasers in all of this? We have this all set up and we just need someone to buy, the better quality from us. So that's one of the things that BRIE addresses is this appropriateness. Who is actually appropriate? So when we talk about BRIE, the bundle within BRIE, because it's a clinical episode of care, there's really 4 cycles that the patient kind of goes through in each one. And the first one is appropriateness. Is the patient appropriate for this surgery? And there's a whole list of things, but they're basically around, do they have a disability despite going through conservative therapy? Have they tried physical therapy? Have they tried other things as well? And if they haven't, they're not appropriate, and they're rejected for knee or hip replacement until they've tried that. Shared decision-making is a huge part of BRIE, and it must be documented in this criteria, and our patients all go through it. So we looked at, when we did our RFP and we looked at all of these sites, we said, you must have shared decision-making, and we looked at what they had. And their shared decision-making is not informed consent, not the same thing that you fill out when you're, right before you go into surgery and you sign your name on 25 pieces of paper that you're not really going to read. Shared decision-making really is a way of looking at what you really need. What is the right thing for you? And then second is fitness for surgery. So you can be appropriate for surgery, but you might not be fit for surgery. So there are criteria around your weight, around, you must be smoke-free. You can't smoke, and it has to be over a period of time. And Virginia Mason will turn people away if they show up and it turns out there's God, that would be terrible. No one would qualify. Nicotine-free. And then finally, if they do go through, then there's all this, all sorts of standards around the surgery itself, and then a return to function. Return to function, then there are patient-reported outcomes that get reported back, and so on and so forth. Because it turns out what purchasers are interested in, and this is what's so interesting for providers to hear, is purchasers are interested in back to work. How quickly are you back to work? And how functional are you? Those are things that providers normally don't think about. And if purchasers don't come forward and say, these are the things we really care about, and start to have that dialogue with providers, then that's really what providers would love to have, is that dialogue with you. What is it that you're looking for? Because we can design around that. And I like to tell the people that I work with at the Healthcare Authority, most of whom don't have a clinical background, haven't worked in clinics, haven't worked in the health system, they've worked on the purchaser side forever. I like to tell them that, with this kind of stuff, what we're doing is we're enabling the providers in each one of these organizations who really want to do the right thing. I've worked my whole career in healthcare, and again, the providers would say, we know the right thing to do. We're just, we're disincentivized to do the right thing. We're not paid to do that. In fact, we're paid to do the opposite. So we're just creating the rules. We're recreating those so that they can do the right thing. So I mentioned that we're talking about our next bundle, and I just got today on my phone, I was trying to read it was kind of hard, from Milliman, some of the numbers on what we should pick for our next bundle. It'll either be lumbar fusion or bariatrics. I kind of lean towards lumbar fusion. Every single payer that I talk to says, do lumbar fusion, that would be a good one. But we're going to decide. And what we did was, to somewhat mitigate the question that we got from providers about this being unfair and so on, we said, okay, we're going to go a year and we're not going to do a bundle. We put out an RFI to all the providers and we said, you tell us what you're doing in bundles. We really would like to learn. Tell us. So we got about a dozen responses back, and we're reporting back on that. And they're all over the map in terms of what they are. But we said we want to start this dialogue. We will be presenting that next week at a similar conference to what you have right here, a purchasers conference, purchasers and providers. But what we wanted to do was to encourage providers with this next bundle. With the hip and knee replacement bundle, it was kind of an all or nothing. Virginia Mason made the cut. It's like a 5-year contract. So nobody else has the ability to even try for 5 years, which is great, right? Because then you get a good price. But on the other hand, we wanted to continue to hold that carrot out there. So what we're thinking of doing this time when we do the procurement is sort of a tiered approach and maybe do an annual procurement. So this year, so probably in November, we'll go out with a procurement similar to what we did before. And let's say there's 100 points of criteria. If you as a provider get between 90 and 100, then you are a center of excellence. And we contract with you and we go forward. If you're between, let's say, 90 and 70 in your points, then you go into a category of you can reapply next year and we will review you again. And we will work with you and try to help you improve on those areas where you weren't stellar. So there's still that carrot out there that we can hold out, and eventually more and more will come along. That's what we're hoping to do. It's more work for us, frankly. It's a lot more work. But we're about transforming healthcare, and we think that's a good way to go. So I will leave you with, I guess now I can open up for questions. I will leave you with this beautiful photograph, which is not of some ruin in Dresden. It is the original Olympia beer site. I thought you'd like to see a picture of it. It's gorgeous. And also, of course, resources are on here, and I assume you'll get some sort of handout. But you can look at the BRIE Collaborative. You can go to our website and find our RFP. It's publicly available. You can copy it. You can do, find, replace, and put your name in there if you'd like. You can also find the Primera site as well. And you can call me. So, any questions? Comments? In the green here?
I guess so. I went to the talk. Hello. I went to the talk at the symposium last year, which I think was by Olivia from Catalyst for Payment Reform, and she was saying that a lot of the savings that they've seen come from avoiding surgeries that they believe shouldn't have been performed in the first place. So when you were talking about the 17% of savings, have you looked into your percentage of surgeries that have been avoided? And then as a follow-up to that, does Virginia Mason get payment when they've reviewed a case and determined that the individual is not appropriate for surgery?
So for a hip and knee replacement, we've only seen a handful of people at the most who have not gone through it because they weren't appropriate for it. We may see more over time, and we kind of thought it would be that way. I know for spine at Virginia Mason, they're seeing about 58% of the ones that they get reviewed, and this for spine only, are not appropriate. That's huge. So if we did spine, I think we would find that. And that's interesting, that's 58% of people whose doctors said, you could benefit by having this. So then they fly to Virginia Mason does the whole review and says, not really. They go back without surgery, but with a treatment plan. So we're not seeing that on our own. And what was your other question? Is that related? Oh, where are the costs the savings coming from? It's simply coming from the fact that, remember the slide I showed with all of the difference in variation in prices?
My question was actually when Virginia Mason determines that somebody's not appropriate,
right?
Do they get paid for that?
So in a way they do. So when they bid this, it included that whole time when, remember, the person's medical records get sent to them. They read them or they review them, they get on the phone, they do a remote assessment basically. So that's sort of in their $25,000 bid. Now, when we do the spinal one, if we do spinal fusion, this is how it will work. And it's sort of two bundles. So there's a bundle for the assessment, so they get paid for that, and then a bundle for if they go through the surgery. It's more complicated. That's a good question. Back here.
In the triangle where you showed you had Virginia Mason and then you had someone else who made you come, what price will they be having to match the Virginia Mason price?
I don't know. If you have a thought on that, we're not sure how to do that yet. Match it or below it, or you have to meet this. We're still trying to figure that one out because it's a little different. How about in the back?
I assume Virginia Mason had in shape already or in process a workflow to get surgeries done that met their needs and kept Walmart and whoever they contracted with happy. Can you speak to how much work went into matching your standards and how much flexibility you built into your expectations?
Well, you're right. Virginia Mason they were already using BRIE. They were involved in BRIE, and they still are very involved in the BRIE criteria. So they were meeting that. But there was a lot of work that had to be done working with Primera and working with us. I mean, we're the state. We're kind of difficult. So I would say that there was a lot of work that they put into it. I don't know how to quantify it other than that, but we spent, we selected them as a bidder in like March, signed the contract in, when was it, September. We should have been earlier, but it took us all that time. But during that whole time until the very end, and still today, we're meeting with them weekly and Primera to talk about any improvements, anything that could go wrong. So I also want to say this is really interesting. Virginia Mason contacted us. So one of the things we have in our contract is, again, I'm going to say it's $25,000. It's not the rate, but let's say it's $25,000 is the rate. And then there's an outlier fee. So if our folks hit some outlier, I forget what it's at, 80,000 or something, then they get paid that so that they don't have these crazy, they don't get hurt too badly. Well, Virginia Mason sent us an email about 2 months ago saying, we've hit the outlier a little too often. we think you should raise the outlier. And we're reading that going, are we reading that right? What? You want us to, yeah, so, and it just speaks to the partnership that this is a part of. And I like to think that we would do the same thing. That if they were really getting nailed on some cost, that a year from now we would say, we got to fix that, because we don't want you to be hurt by that. Other questions up front?
The state of Maine has passed legislation to try to get some sense of transparency in what hospitals were charging for various procedures, but it's been a nightmare because of infinite variances that people say in the types of various aspects of each procedure. You had a matrix early on in your presentation where you were showing the frequency and the cost of hip replacement at different hospitals. How did you deal with the phenomenon of the complaint about variance in the cost of the specific procedures?
How did we deal with the complaint about the cost?
No,
We just
the cost of, how did you develop that matrix when people complain there are so many, or hospitals complain there are so many variances?
Milliman did it. So Milliman did it. We had a third party who did it. So, they looked at we defined what would be included in that claim bundle, and it included PT afterwards, and all of these things, that imaging and everything before, and basically they did the analysis, and they told us by hospital who those were. I mean, we knew who those were, but we couldn't decipher what the rates were, right? So that is, they're very tricky about. And we're trying to do that in our state too. So if you guys figure out how to create transparency in pricing, let us know.
Yeah.
But we aren't getting anywhere with that either.
Okay.
Does that answer your question?
I think it's as close as you're going to come.
Yeah.
I also wanted to know whether other states are doing what you're doing, or how comparable what you're talking about Lowe's and Walmart doing might be. What
Lowe's and Walmart are doing is very similar. We basically copied the approach that they'd taken, and what they did was it's really Pacific Business Group on Health that put this together and created this with the TPA that they went with, which is Health Design Plus, is what they're called. It's a very small sort of an outfit, very committed. I mean, it's really their mission, and we just kind of said, yeah, that sounds good. Let's do it that way. Other states, I haven't seen any other states do this. On the Medicaid side, a lot of states are doing this in a retrospective model for Medicaid. Within our own state, I'm trying to encourage the Medicaid side of the house to do this, because in a way that kind of raises all boats. Every provider then could be involved, but in a retrospective approach. And retrospective is great. It just depends on your market and the sophistication of the providers. We were just lucky to have a very sophisticated provider like Virginia Mason in our market that was willing to do prospective. Others wanted to do it too. They would have gone for it.
And one last question, which is really more for the association, and that is whether you have tried to develop the kind of matrix that she showed on cost and quality for types of operations.
We have looked at that before and actually presented, a number of years ago, I personally did using the all-paid claims database from the MHDO, and actually looking at her matrix, when I saw it, I was surprised actually at how little variation there was compared to what we've seen even in Maine before. I know you said there's a lot of variation.
Well, it's average too, though.
It was average, which I
Because some
heard
of
you
them are-
say, but we have looked at that and it's phenomenal. And to your point, you got to get into the claims and make sure you're really comparing apples to apples, and look at all the modifier codes and all this kind of stuff. But there is amazing variation. And I would say, and I'm just going to add, it's across all kinds of services, not just orthopedic surgeon, knees and hips, but full lab panels, everything else. And this is part of Elizabeth Rosenthal's point. Yeah, sure. Give me your card, or I'll get your address, and I'll show you. But it was about 2 or 3 years ago. We probably actually more than that, but I will. Yeah, I'll send you the slide deck. Sure.
Thanks. Additional? Was there a question back here?
Consideration to go out of state?
To go out of state. You know, we talked about that a lot, especially to go down to Oregon. In Portland, there are some centers of excellence out there. But we're the state of Washington. We kind of, that would look bad. Yes.
So I'm presuming that Virginia Mason is a completely employed model.
Yes, they are.
And
an
so when
employed
you
model.
went into your bundle negotiation, you were negotiating with one provider and that's it, it's a full spectrum. Did you do any negotiations with where there was an orthopedic group and an anesthesia group and a hospital and a rehab group and things? And do you think bundles would be possible in that situation?
I love that you asked that question. That's such an important question, because when we got back these, bids from folks, basically their applications, maybe I was naive. I worked on the provider side. I know what I would have done, but I was surprised to see that we got back. For instance, we got back an application from Proliant Surgeons, which employs. It's like a huge provider group of just surgeons that does orthopedic surgery, like all across the state. And they're like, hey, we do this, here's our application. And we provide services at Overlake and Multicare and other places. And we're like, well, that's cool. And then we got this stuff we got applications from Overlake and Multicare mentioning Proliance. And we were like, why didn't you apply together? Like, it's so clear that you are not working together, that you do not have a center of excellence. If you're not even applying together, you can't, like they would say, here's our data, because we required that they submit a bunch of data about quality, and they'd say, if you want to see the hospital criteria, go talk to them. And the hospital would say, if you want to see the provider criteria, go talk to them. And we're like, well, what's this? You're supposed to all work together. You should be, if you're really trying to improve quality, you should be looking at each other's data. So we got that question too, doesn't this just require that it be, an integrated system like Virginia Mason? And I still say, no, I don't think so. I mean, they put together LLCs all the time. Why don't they put together an LLC and say, because we didn't want to pay all of these folks, we just wanted to say, here, you take the money and you divide it up and figure it out. And so they'll be at risk for every anesthesiologist and hospitalist. And you remember the circle prospective payment? We just want to say, here's $25,000, you figure it out. Does that answer your question? Yes. And that's the way to do it. You can do that with retrospective as well, but it's just not as clean. Any other? Yeah.
Hi. You did have on your list end-of-life care. That seems a little different than some of the procedure-oriented things. Have you started working on that and how you might see that working out in this system?
Yeah, so end-of-life care. So those, you're talking about BRE reports, all the BRE reports. Is that what you're referring? That said end-of-life care?
Well, you just had on your list that end-of-life care would be some a type of care that would be in a bundled payment.
It could be.
So just wanted for you to speak about that a little bit, because it seems a little different than some of the other things that one would have, like a hip replacement.
Well, we've talked a lot about, there's a lot of talk among people who talk about bundled payment, about, less procedural. For instance, on the Medicaid side, if we look at Medicaid, we probably won't do something that's procedural, because what are their issues? It's like asthma, diabetes, chronic care. And there are bundles around oncology. There's an oncology bundle that CMS has. So we are open to looking at that. It's just harder. It's harder to figure out how to do that. And eventually we'll get there, I think. But that's a really good one. Yeah, end-of-life care. Wow. But BRE did do a whole report on end-of-life care. It's not a bundle, but it's protocols. And it's from an insurer perspective. What we want the insurers to do is to make sure that they cover that. We want to make sure purchasers enable the kinds of things that they say are quality. Okay.
I just had one question. So I work at the Network for Regional Healthcare Improvement, and one of our regional healthcare improvement collaboratives is the Washington Health Alliance. And in recent conversations with their team, they were talking about the development of a 55 sort of measure set for quality, and how that was obviously somewhat of a labor-intensive process, and you have to build a lot of trust and all of that to get to that point, but that then they're now able to use that for value-based contracting and purchasing. Is that measure set something that you're using?
Absolutely. Yeah, we're really involved in that. So what she's talking about is that at the state, there was a lot of work led by the Washington Health Alliance, which is sort of your counterpart there, to come up with what we call the common measure set or core measure set. And what that is measures around quality that are defined exactly the same way. Here's how you define the denominator, here's how you define the numerator. As you know, if you're a provider, as you know, every single health plan has a whole set of different quality measures. There's like 1 million of them, and you're measured in different ways. And so how can you, it's like performance management, how do you improve if you don't know what you're being measured on? And it costs them a lot in terms of time and energy and money, really, to try to meet those quality measures. So we worked together, we're supportive of the Washington Health Alliance to come up with this measure set, which they did. And it's enacted in law now. I think it's in statute. That they keep increasing it. It bugs me, but they started with 52, which is easy to remember because that's how many are in a deck of cards. I can remember there were 52, and now I think it's 55, and they keep adding. It keeps growing, but it's very important. And what we've tried to do is for all of our contracts, those are the measures that we want to use. And for our fully insured populations and also our self-insured, we're trying to use those as well. Does that answer? Any other questions? Yes, in the orange.
Yeah, assuming that this has been successful for Virginia Mason, assuming that this has been financially successful for Virginia Mason, do you have any transparency on the retrospective financials for them? So in other words, you're prospectively giving them X, which is 25,000. Do you have a sense of how they're doing retrospectively, financially?
With ours?
With your payment?
They love it.
Okay.
They love it. Yeah, they know that they're going to get it. They're not waiting. They're not fighting. They're not, waiting a year later and then finding out what they may or may not have. Did they meet the target or not? They know. Plus, it's like a week later that they get paid. I mean, almost nothing do you get paid a week later if you're on the provider side. So for them, it's really worth it. They've put a lot of work into it. They'll have a lot of infrastructure involved, obviously. So, we're happy to reward them for having done that. But I think it's shortly after we announced that they had won this, they've got Lowe's, they've got Walmart's. We were the first ones in Washington State for them, a local big purchaser for them to win. And it made them sort of sit up and go, wow, okay, well, maybe we really do have something. And maybe this is a strategy. They hired somebody to specifically try to market for them those kinds of bundled payment approaches.
So then I would wonder if there are other huge health system practices coming to you with proposed concepts for bundles. Has that started happening?
All the time. All the time. Yeah, they would love to. We can't do it that way because we have to go through a competitive procurement process similar to what I talked about. But it's interesting because one of the large providers in the state, I know I was talking with her at one of the conferences, and she said, I'd love to talk with you, let's have coffee, I'd love to talk with you, because next time, we have locations all over the state and all over, and it was like, you still don't get it. You still don't get it. One of the hard things was to explain what a center of excellence is, right? A center of excellence is excellence. It's not, give us a low price for everything across your state. We actually had a challenge explaining to people, a center of excellence, it's a place where patients go and they get care from physicians. There are beds. That's a center of excellence, not, give us a discount off of anywhere. We wanted our patients to have, if we'd had 2 centers of excellence, we would have demanded that that the patients have the exact same experience as much as possible. at those places. So yeah, we have people coming to us with that, and we say, read criteria, and we will do a procurement, and we hope you win. And we're happy to talk with you more about that. Does that help? In the back.
Question is around prospective versus retrospective, and I'm curious, two questions. One, the timing of setting the target for retrospective, is it about the same, would it be the same time as the prospective setting, so that the providers would be able to track to that expense? And then secondly, was cost a factor in making that decision? Was one more cost effective than the other approach?
So the way that the providers made the decision, it was a bid, literally. We said, we want to buy these services. We want to buy conference tables. What's your bid? We want to buy hip and knee replacement based on this quality. How much are you going to charge us? So that was kind of how that was set with prospective. With retrospective, every payment model is different. I think CMS, maybe somebody can correct me on this, but I think that they use a target price. What they do is they look at within your area at the end of the year, they look at it and they see what all the providers in your market area charged, and then they take an average, and that's that target. So you didn't know what the target was ahead of time. That's normally how it is. But it could go that way. It could say, here, aim for 25,000, and you absolutely could do it that way.
Okay, thank you.
Yes. Microphone.
So I was interested in terms of the development of the criteria. If you were involved in that process, how long did it take?
I was not involved in it, but it took years. It took a couple years. And if you go and read the criteria, you'll see that they, it's evidence-based, so they looked at all of the studies that they could find. It took a couple years, and then what they'll typically do is they'll put out the criteria and say, this is what we're looking at, give us your feedback. So everybody has a chance to give feedback on the criteria, and then they finalize it. This year, incidentally, they are looking again at sort of renewing the bundle for hip and knee replacement because, evidence is always changing, right? And there's some questions about, I'm not a physician, about injections and whether or not you do an injection at a certain time and blah, blah, blah. So they're looking at the new evidence on that and does it increase infections and so on.
And how much does the collaborative rely on hearing from national experts versus hearing from local providers?
It's very much based on evidence. So they're looking at national standards. They're looking at evidence, just like anyone else would. So, maybe there's something in Maine that, a collaborative, but I don't know why you wouldn't just use a collaborative that just happens to be in Washington State, but I don't know how that would work,
I was actually going to ask you a follow-up question. From your sense of those criteria, do you think there are things unique to the systems there and so forth? But you just answered that question.
Yeah, I don't think so.
Mm-hmm. We may have local folks that have an opinion about it, but...
Opinion isn't good enough, right? That's called opinion. But you're right. We do have payers who say that they're using it, beginning to use it. Medicare is very interested in it. They've based a lot of health policy groups are using it and trying to push. They don't always name it, but it's behind a lot of the bundled payment quality approaches. Somebody have a mic back there? Okay, back there first.
This on? Oh, here we go. I'm with the High Value Healthcare Collaborative, and we've done a lot of work with Virginia Mason in this space. And a couple of points. One around what you mentioned of the CMS target pricing. It's becoming more and more so that it's weighted based on not just that regional average, but also that individual facility's historical average. And I'm wondering whether or not you've worked with CMS in these conversations around bundled pricing, because this is absolutely something that they're challenged with as well. And I know that's an area where we've engaged with them as well. So interested in any of those
Yeah.
conversations?
Definitely had a lot of conversations with them about it. They kind of can't figure out how they would do something similar like this. And it would be challenging to do something like this. But there are aspects of quality that I think that they could pull into it. It would take more administration on their part. So they're interested. I mean, frankly, in some of the talks that I've had with them, it's like, well, that's too hard. So, oh well, whatever.
And another follow-up, in working with setting that bundle target price for what you would pay Virginia Mason, for example, was there any pushback ever about the patient complexity case mix, and understanding whether they'll be able to maintain an expected risk profile for whether or not that would be an appropriate payment for who they're actually seeing to give these procedures to?
Very good question. Everybody talks about that. Remember the Bree criteria? Appropriateness, fitness. So if you meet those, then you have...
That essentially levels your risk profile.
It levels the risk profile. Exactly. And it's interesting because it's like people think about this differently, because then one of the criticisms that we get, and that was in that letter that I showed you, oh, they're just cherry picking the best people. And we're like, no. They're taking people who actually are going to have good outcomes as a result of, there are people who, and we've paid for them so far, who do not meet the Bree criteria because of a number of really, really serious health conditions, and yet the one thing, that they really do need to have a hip replacement. So we've paid for someone, but that's where you have that outlier. So we actually, when they gave their bids, they ended up giving a bids, I don't know how many of you know this, but DRGs, based on DRGs. So there's DRG 469 and 470, and I think I always get this wrong, but I think 470 is with complications, or maybe it's the other way around, 469. So they gave us a bid for each of those. And so if we get one that does have complications, then they would get that higher rate. And then if it goes crazy, then the outlier gets paid. But it was harder. I don't. I don't think we have it. We have a higher. There's a floor, but not a ceiling for that. So I mean, we don't want them to get killed. Things happen. But it was so interesting trying to talk to our own folks about that within the healthcare authority to try to explain that, because they couldn't imagine a situation where. What if this happens? This is what they do all the time. What if this happens? We're going to get appeals. We're going to get this. And we're like, no, they're really at risk. They're really at risk. They're at risk. It was just so hard to get across to our own folks. And I mean, we had to get it into our heads. We had to think of every possible situation. So it's quite an interesting discussion. Yes?
You mentioned that 10% of your folks chose this option. That means that, why didn't you have the 90? Is there not much price difference, or
it tends.
chose not to go this route?
Yeah.
They pay more?
I don't know. Yeah, they pay more because they're paying their out-of-pocket, whatever that is.
How much might that be?
It could be as much as $1,200. So depending on where they go with a coinsurance. Did I show that I don't think I showed this, but what we're saving people, did I show that out-of-pocket people are saving $855 on average? Out-of-pocket, that's a lot.
Have you heard why the 90% aren't?
No, we're dying to know. I mean, it could be because they have a relationship with their physician. That's the first thing that we think. It could be because they don't even know about this. I mean, my own friends, I see them at parties. They're like, what have you been working on? And I tell them, and they're like, I work for the University of Washington. I didn't know that was available. So we try and tell people about it, but we need that poster boy to come forward. That's what we're waiting for.
Is there a price point at which you think you get a lot more participation?
I don't know. I mean, state workers, we got everybody from, people who really are, practically at a Medicaid level to, I mean, we think that they're probably pretty price sensitive. And obviously it's working because we have letters from local providers who are saying people are leaving the area because they can save money. Okay, so it is working. It's Walmart's and Lowe's, I think, is getting ready to make this mandatory. You will pay for, it's mandatory in the sense of if you don't use the Center of Excellence, it's considered out of network. So then you're paying like 60%. So, I mean, we could go that route, but not right now, probably. Right here? Okay.
So we actually do have bundles in Maine through the Maine Heart Center and doing heart surgery and things. And it's sort of like the parking thing, but one of the biggest challenges that we've faced in setting up bundles, and we've got about 2 years of experience now, but one of the biggest challenges in setting up the bundles is how do you process the claims for them? I mean, it's a different, what level of, and so I guess, how did you in Primera solve what level of detail do you want on the claims, and, you know,
That
are you
was
just, yeah.
Primera and Virginia Mason figuring that out.
Do you know what they're doing?
No, but they'd be happy to talk with you about
Okay.
it. I can give you the name. Often when I've given a lot of these talks, and often what I'll do is I'll go out with a person from Virginia Mason and a person from Primera, and they can usually answer those questions. It's really good, and you should find out what they do. It's kind of unique. They're working on it's still a bit of a manual process at this point. They're working on doing an electronic invoice, which will be like a first in healthcare. It's brain surgery.
No, it's the manual processing of these bundles is kind of hard sometimes.
It is hard. It's hard.
But
right?
it's not brain surgery.
But it's not brain surgery. It can be done. Yes. Does that mean 5 minutes? Yeah. Oh, okay. Time flies.
I was just going to say something, I think, in response to Ted, what you were saying is the one thing that Marcia hasn't shown is the lack of revisions and literally the quality. I remember
we have no complications so
there are
far.
no complications.
None.
I remember PBGH, Olivia Ross showing that, and it's just stunning, the quality across the board. And I can remember visiting BIW and the unions there and showing them this data, and the union members were all over it. They got it immediately, and that is a huge part of this. It's just not about the cost, but the quality is, and you showed the variation.
Mm-hmm.
When you just take all those complications away, it's phenomenal. And so.
Yeah, a lot of these, when we talk with purchasers, and we really try to encourage, other purchasers get on board. But it's hard to do, and they're worried. Oftentimes, what we hear, especially in the area where we are, there's really low unemployment, and it's the middle of technology. We have Amazon and Microsoft, and all. People are having a hard time even finding employees, right? So it's tough. So the last thing that they want to do is to say, we'd like you to come here, but we've got this kind of weird thing that we do with healthcare where you have to go to these people because it's cheaper. They don't want to do that. So, what we're trying to say with this, trying to emphasize with this, is that we never talk about cost, except for with purchasers. And now we finally do have some results, but we didn't do it for costs. We did it around quality. We always just talk about that. And if you talk to Lisa Woods from Walmart, who goes out and talks about this, she says the same thing, which seems so funny coming from Walmart, right? Really? But she says, we did it because of quality, and we do it anyway, I'm sure they're saving a lot of money. Yeah, and so in order to get, you sit there and you talk to people about, why wouldn't you want it? It's the highest quality, we vetted it, everything is taken care of, and no out-of-pocket cost. What can you find fault with? Okay, are we done?
No applause yet.
No applause, all right. I guess I didn't need it. Sorry. They're tough here in Maine. They're really tough.
I want you to give her more than you were going to give her. And the reason is I talked about leadership in the purchaser community earlier this morning, and this is a purchaser doing leadership to do value-based purchasing. And remember, it was a purchaser saying when a plan said we can't do it, it's too complicated on the claims, they said, okay, we'll go find somebody who will. Okay. The other thing for me is it's not the purchasers going off and kind of doing something on their own. It's an incredible partnership with a provider who's willing to do this to achieve that long common goal, right? And so it's just phenomenal for us to see you do this, because this is what we're betting the coalition on, this kind of thing happening in the future. So thank you so much for coming.
Thank you. Thank all of you.